So now we come to our question and answer session. So I'd invite all the speakers to have a seat out the front, please.
Question I ask you every year, with circulating melanoma cells, the diagnostic tool, how's that research going on that?
No, you'll need, yeah.
Yeah, so there's quite a lot of research that's been underway looking at the blood and different aspects of the blood and whether that can be used to follow progress of for individual patients and also be used for certain diagnoses. So there are two things you can look at in the blood that are quite well researched now. One is to try to find melanoma cells floating around in the blood, and the other is the DNA that's derived from the melanoma in the blood. And the circulating cell research is really, I would say, stalling. It just hasn't really progressed for technical reasons. It's not that easy to actually reliably purify melanoma cells and count them in the blood. What is going much better, though, is the DNA in the blood that's released from the melanoma. So what are the findings so far? Well, what is established now is that when you need a BRAF test really fast in a good proportion of patients, that can just be done on the blood now. Okay, so that's established. We prefer to still test the tumour for the BRAF mutation test, but if there's a need to find out really quickly, you can do it on the blood now. The other thing that's progressing quite well is research around what happens after surgery is completely removed the melanoma and you can't see anything on a scan. Can you detect people at higher risk or lower risk by whether or not there's this DNA in the blood? Now that is progressing, quite well. And what we're hoping that's heading towards is we might be able to really give the so-called adjuvant drug treatment, so the targeted therapy and the immunotherapy, to the people that really need it, because the DNA is in the blood, where maybe if the DNA is not there, there might be less need for drug treatments and the surgery, and Michael was cured with surgery all on its own. That's the hypothesis, and so now the big trials have to be done to determine that, and they're underway. Actually, a collaboration between Australia and the UK is looking at whether one might be able to restrict the use of immune therapy to people that had stage 2 melanoma by whether or not there's the DNA in the blood. So it's coming along, but not routinely. We don't routinely use it outside of a research study at the moment.
Thanks, Grant. That's great.
I'd like to thank the speakers for their work tonight. I've got a question for Grant, Professor Grant. I've been on Keytruda for 4 years. You didn't mention Keytruda tonight in your talk, and I'm wondering whether there's further work on that. And would you say that if you've been clear on CAT scans for the last 2 years, should you still continue on that? And if it returns, can you still get back on the Keytruda treatment?
Yeah, so Keytruda, I think most in the room will know that's one of these PD-1 immune drugs, and there's a whole number of them now. They're actually probably the single most popular class of drug to be developed in the history of medicine now. There's, believe it or not, Keytruda and another 42 similar drugs either approved in clinical trials or planned to go into clinical trials. It's unbelievable. It's just, because it can just work so well and in other cancers. So this is a common question about how long do you need treatment for and can you stop treatment? And there are trials underway, what we call discontinuation trial. Half the people stop, half continue, and then you work out, if you can stop. And but what we do know is that in the first trials with Keytruda, if treatment stopped at 2 years and you were either in a complete response, nothing seen on scans, or even in a partial response, in other words, things had shrunk down but something's still left, it's actually quite safe to stop after 2 years of therapy, in that with another 2 years of follow-up after stopping, over 90% of people had not progressed. So it's possible to stop, but it has to be individualised. There's various reasons why to stop or not stop that have to be discussed with your doctor. But stopping is now, what a great conversation that we're having to have now all the time about stopping treatment for life-threatening illness. I mean, it's tremendous to be in that situation. So yes, we're starting to think that some patients definitely can stop. I might share with you actually a conversation I had at lunchtime today with a colleague, which Alison, it wasn't about melanoma, but it's a sad story that, so there's a young student visiting Australia who got a sarcoma, a rare type of a sarcoma while the student was here. And it turned out that there were changes in this cancer that suggested that Keytruda would work. And so this young kid in his 20s, sold some assets and cashed in all his superannuation that he had overseas to pay for the Keytruda. And but he's only got enough money for a year's treatment, so they're having to have the big conversation now. What does he do? Does he just stop? And so they came to me and they said, same question, is it safe to stop? And I said, well, we don't know with rare types of sarcoma. But I shared all the melanoma experience to hope to give advice to this young guy that maybe he will be able to stop. So it's a big question. Nice question to have, that for life-threatening cancers now you can talk about stopping treatment and maybe cure. Yep.
When you were talking about the sequencing for BRAF positive, whether there's similar type trials for BRAF negative, so where immunotherapy hasn't worked, or where you could match immunotherapy with another with another drug that might identify the cancer?
Yeah, no, that is a really great question, and the answer is not yet, because there's a whole list of different treatments that are showing some activity after the first-line immunotherapy has stopped working or didn't work in the first place. And we're still working out which the best ones are. And so I think we're probably, there's an obvious thing now about the BRAF and the targeted, but my prediction would be that probably 3 to 4 years from now there'll start to be questions about sequencing of different types of immunotherapy as well. But we're still working out which are the best alternatives to the Keytruda or Opdivo or Yervoy classes of drugs, and if there's other ones that can be used as well. But once there's some signals there, then there'll be exactly the same questions. Can you sequence them? A really interesting another treatment is, and Jane mentioned that she had radiation. So there may be sequencing questions with radiation with the immune treatments. Is it best to give radiation first? Do you give it during? When do you give the radiation and in what dose? So, I think that's going to move forward pretty soon, because all the signs are suggesting that radiation helps immune therapy and might work well together. I don't know if Jane's got any comments to make about all of this, having experienced it.
You've had what for?
Yeah, thanks. It's interesting you say that. Initially, and Megan can help me out a bit, but initially radiation was given to a mass under my arm as a, I suppose, palliative reason rather than surgically remove it. But also there was a thinking that at the time I was on Keytruda, and there was thoughts around, obviously no evidence, but thoughts around that it could provide a boost effect to say, if Keytruda is not helping on its own, maybe the two combined would actually could give an effect. I didn't show a response on Keytruda, so I subsequently came off it, and that's when I went back on to another targeted therapy, which is the one I'm still on now. Yeah.
I was going to say, every summer you see around Melbourne these new ads which go up on trams and trains, and they're mainly young people, and they're always well dressed. and they're sun seekers. It's an amazing type of ad. I don't know what, I hear all the promotions about slip, slop, slap, but then you've got the private sector promoting these ads saying be a sun seeker. And I just wonder how that gets balanced out between public health campaign programs and people promoting people to be in the sun.
I can be pretty crude and say that, the public health campaigners are virtuous, i.e. us, and the rest of them are filthy, money-grabbing, probably lawyers out to make a large amount of money very easily. But, that's a bit of a simplification. The fact of the matter is we live in a free society and people are allowed to do what they want to do, and it's a matter of educating people to perhaps get some of the advantages of the sun-seeking behaviour, but on the other hand, keep themselves safe at the same time. That's our job, is to make sure people are aware of the risks and to give them advice about how they might be safe. I don't think anybody can say anything more than that. I don't think we're ever going to quite legislate against that, but I suppose the example, and Grant's had got considerable experience in this area, was that of sun tanning beds, which there was enough evidence to suggest that this was an industry out of control, and that there was really there was nothing really healthy about what that particular industry was promoting, and the decision was made at a governmental level after considerable agitation from the Cancer Council, and Claire Oliver was the sort of lead person, and Grant had a lot to do with this in convincing our lawmakers that this was an appropriate thing to do, is to ban sun tanning beds. That's the only other example I can think of. But there's always people complaining about living in a nanny state, but they don't look at the other side of the coin and say, well, in a free state, people should really only advertise things that we know are safe to advertise.
I talk to a lot of people because there are more stage 1, stage 2 people, and the question that I often hear is, how will I know my melanoma has come back? And that ties in with scans, of course, and then I find that people are confused about the type of scans and what they're looking for. So that's 3 areas in one question for you, Michael.
Well, we'll get another 2 hours. This is a really complex question, and I think it's very fair to refer you back to the Australian guidelines. So if we look at stage 0, which is in situ melanoma, we know that for all patients, whether they've got an in situ melanoma or any other melanoma, we know that they are increased risk of both a new melanoma or a non-melanoma skin cancer. So anybody who's been diagnosed with a melanoma should be under a skin surveillance program for the rest of their days. Okay, so that's easy. That doesn't require anything more than a good experienced eye, good local doctors, doctor in a skin cancer clinic, dermatologist, or the treating clinician, such as a surgeon, taking responsibility. For patients with very thin melanomas, that we define that as less than 1 millimetre, that are without any adverse prognostic features, we know that the survival at 10 years is going to be 98%. That's the fact of life. There is no role for any staging surveillance scans in that group of people at all. We know that we need to look at the primary site for the first year or so, but after that it gets back to the yearly skin examination, and there is no role for anything else. When we sort of formulated these guidelines about how people are followed, it brings into play 2 almost competing issues. Number one, there is a limit to what we can pay for. So there has to be a decision about what the community can bear. And the second issue is, it's got to be, anything we do has to be, it has to be shown that it's going to improve patients' health or outcomes. And nobody's ever shown that doing lots and lots of scans actually improves patients' outcome. It does not bring about cures in the patients, and that 1 or 2% of people who are going to recur, and it does all sorts of bad things. There are downsides to scans. The first thing that everybody should remember is that no one scan ever invented or blood test or anything else in the whole of medicine is 100% accurate, except possibly a post-mortem. All right? Because if you're dead, you're dead. If you're not, you're not. So that's the first thing to say. There is always going to be a small degree of problem. Now, my little finger has many uses, but one of them is if I show you half my little finger's nail bed, that's what a PET scan needs to show you you've got disease. And Chris's point about what we've proven is that you didn't have a melanoma this year. That's exactly what a scan says. A scan says you do not have a melanoma that is bigger than half my little fingernail, all right? So is a PET scan or a CT scan of any great value for the vast majority of people? It probably isn't. And you've got to explain that to people. The third thing to remember is that scans are not innocuous. They all involve radiation. And as time goes on, we are becoming much more careful about using radiation willy-nilly. So, for instance, many of you would not know that it almost requires an Act of Parliament to do a CT scan on a child. It's that serious these days that we limit diagnostic radiation in children because of the potential for causing cancers in the future due to the radiation. And I think we're going to see a little bit more of that in the future. And the next thing to suggest to you is that there is another reason why you've got to be careful about scans. What if I order a scan for someone for no good reason and I see the patient next week and I've got to tell them, look, the good news is we haven't seen any evidence that the melanoma's gone anywhere, but you've got this funny thing on your back. Have you had back pain? Now, if I asked everybody in the audience who's had back pain the last 6 months, all of us have put our hands up. So the point is, does this little bit of back pain you've had in the last 6 months and this funny-looking thing on the CT or scan or the PET scan actually mean anything? And the answer is, in the report, the radiologist will write something like, there is abnormal uptake in the third lumbar vertebra. This is of uncertain diagnostic significance. This is probably traumatic or related to ageing or something or other. However, suggest further intervention or workup or surveillance. So I then tell you you've got something there. How do you think you're going to feel about it? What if I then say to you, we want to stick this bloody great needle into your back and pull some tumour out or something or other out, and you come back next week after having that done and I say, great news, your bone marrow biopsy or your vertebral biopsy or whatever it is we've done is negative. And everybody says, isn't that great? No, wrong. I have committed a serious harm on you because I never should have done the CT scan in the first place, and you never needed to be bothered and worried about having a possible diagnosis, and you should never have had somebody shove a bloody great needle into you because sometimes bad things happen when doctors do things to patients. So there is a downside to scans in all sorts of ways. So when we order scans, you've got to be certain that what you're going to achieve is going to be in the patient's best interest. So for early stage melanoma, there is no role for scans because the disadvantages outweigh any possible benefits if there are any. Now, I'm a bit evangelical about this and I've waxed on longer than I should have, but I'm happy to
talk about it.
I'm happy to argue with anybody, particularly some of my colleagues, about it if they wish.
Just with the scans, and I think one of the things we do is that we make sure there's not too much of a gap between the scan time and the appointment. Because if anyone ever has a blood test or a scan, it's often at that point it heightens anxiety about the whole scenario, so this is something we carefully consider when we're doing our scanning schedules. Because if we just scan everyone every 3 months, you're going to have this heightened anxiety about your cancer diagnosis, and maybe often not for any real benefit. So I think that's something that shouldn't be underestimated, is the effects on your psyche about having all these tests.
What about people who find they're doing their own self-skin check and they find something dodgy? So it's new or it's changed, and they're in a bit of a panic, and they ring up their dermatologist. Usually you can get in to see your GP, but with your dermatologist they're told, oh, no, we can't see you for another 2 weeks.
Well, actually, there was a study on that in America.
But my question is, I'm not going to die in 2 weeks, am I? It's okay to wait 2 weeks if I found a dodgy spot, lesion, mole?
Yes, that's usually... yes, I think in the vast majority of cases, I mean, at some point a melanoma will spread. You can't pick which exact time that is. You know, could it be in that 2 weeks? Well, you'd have to be pretty unlucky, but, you know, it's unlikely. But they actually did a bit of a study ringing up dermatologists in the United States and asked for an appointment. And one was for a changing bleeding lesion, and one was to have Botox, and you could get in really quickly for Botox. So my recommendation is ring up, say you want some Botox, and while you're there, well, I'm here, doc, can you just look at this? So that's true. That actually is a problem. So, but it's a different world over here. Generally, most dermatologists, if you're an established patient there, have rapid access type protocols. So if someone rings me up, I'll get them, send them a photo, and we have a look and try and triage it. Usually the photos aren't good enough quality, so he says, I better put them in this week or next week. Because again, it gets to that, it's like ordering a test. It's that anxiety waiting to get the assessment. And I can tell you 80, 90% plus, 95% plus are benign little keratoses. They're harmless. But that... you don't know that until you're told. So most the other thing is you go to your GP and get them to do the phone calling.
Yeah. The other thing is, I mean, I would be probably on the phone to you 24/7 if I was a stage 4 patient and had all these questions and I was on one of the therapies. What are you laughing at? Oh, yeah, okay. I think it's many patients. Do you mind the patients calling you? I mean, seriously, because many of them feel, I think, that they're being, annoying you or, this doesn't really mean anything and should I contact you? And, before you know it, a week's gone.
Yeah, I guess, the contact that we have with people changes over, I guess, the course of their treatment. So often in the beginning, when you're starting on something new, there's lots of questions, there might be new side effects popping up. So we often find in the beginning that there is a lot of that, contact, early on, and that's certainly what we're there for. We much prefer that patients let us know what's happening than not. And then usually as you get a couple of weeks down the track and, you're feeling a bit more comfortable with things, usually then that contact will sort of ease off a little bit. So it does, change over the course of things happening. Obviously, we're not there to answer the phone sort of overnight, but, we're certainly, always more than happy to take, those queries and questions and don't want people to feel like they're bothering us because that's sort of, one of the main functions of our role.
Oh, great.
I was just wondering if you've got any idea of how many melanoma nurses in Australia?
Oh, that's a good question.
We have a lot of breast care nurses.
Yeah,
and
certainly not as many breast care, like melanoma nurses as breast care nurses. I think the main, main cancer centres have like a melanoma nurse. So that I know there's at least 8 that I know of that are around Australia. Yeah.
But that's actually very small number.
Yeah, very small number, yeah. And often, like, say, I know down in Geelong, there's a nurse, Donna, who she covers, like, 3 sort of different cancer streams. So they're not always just, specifically for melanoma. Yeah.
Okay, thank you.
So after 5 years, so you finish with all the scans and that's all done and you see a dermatologist. So what about the blood tests? Would you recommend still doing the blood test?
There is not a blood test for melanoma at the present time. Grant was talking a little bit about circulating tumour cells and tumour DNA. But no, there is no routine blood test in melanoma that we would do, full stop.
Okay, so
at any stage.
Okay, so not with the, just checking with the
LDH?
Yes.
It is not a very good test at all at pricking melanoma in the asymptomatic, in the patient who has no symptoms.
Okay, all right. Thank you.
And I guess maybe, Grant, this would be directed to you. I have people who are really concerned about their diets. And so I have some people saying, I'm going to really care for my gut by, eating lots of green veggies. And others say, oh, no, you should take a probiotic. And then others will say, oh, no, sugar causes cancer. I'm going to have a sugar-free, carb-free diet. So I'm just wondering which part of that you'd like to address.
Yes, I think there's two interesting aspects that, there's some sort of evidence building in that I can comment on. And, when I gave my talk, I talked about this, that seminal cancer research paper about the hallmarks of cancer. So one of them was fuel for cancers. Cancers, use a lot of glucose and a lot of other metabolites in the body, and it's all wired differently to normal cells. So that has led to an idea that, well, can you starve the cancer? And the problem is that if you try to starve the cancer, you starve the body as well. And so there's no evidence that limiting carbohydrates will starve the cancer once a cancer is established. And that's because cancers are wired, they just suck up all the nutrients they can from the environment they're in, and it doesn't matter how much you put into the body or don't put into the body, they'll find, the nutrients to continue to feed themselves. However, having said that, excess sugar consumption and being overweight are all risks for getting cancer in the first place, for getting a new cancer. So, so we certainly support cutting back sugar and sugar intake, but carbohydrates are an important, necessary part of cellular metabolism, so you need it. Now, the other aspect is about other aspects of diet. So with those sort of hallmarks of cancer, so there was a great question asked of this bloke, Doug Hanahan, at our conference last week was, well, are you going to write the hallmarks again, and is there anything new that's come up about cancer since you wrote that famous article back in 2011? And the answer was, well, yes, there is. It's the microbiome. So everyone heard about microbiome. You probably have pretty interesting stuff where the bacteria in different parts of your body, especially in your bowel, can affect all sorts of different processes in the body. And so it's very early days with cancer on the microbiome. We've got so much to learn. But the early evidence is that, the healthy Cancer Council Heart Foundation diet, lots of green leafy vegetables, lots of fibre, generates more diversity of different types of bacteria in your bowel. And interestingly, that seems to be a good thing for the immune system. So there's not any strong relationship between diets and getting melanoma. We've never found that. However, early data that, the Keytruda treatments and similar treatments to that, that maybe they work better if you've got a diverse microbiome, diverse meaning lots of different types of bacteria. And so there's all sorts of research going on now to maybe you can actually make the microbiome in your bowel such that the immune treatments will work better. So talking about the question about sequencing, down the line, another 3 to 5 years from now, there may be all sorts of questions about what type of diet you should be on and combining with different immune treatments, and when should you change your diet and things like that to get it all right. Do you go on a diet first and start the immune treatment, or can you do it the other way around? Those questions may emerge. Too early yet. What's my advice? Cancer Council diet's a great diet. It's a very healthy diet for many aspects of your health, and including if you follow it, you'll get a good microbiome in your bowel.
Thanks, Grant. Anyone else have a final question? Oh.
Are all sunscreens equivalent in their protection?
Thank you.
Okay. Well, firstly, in Australia, you have a regulation where you have an SPF factor listed on the sunscreen. And so that's generally fairly rigorously tested for. The main problem with sunscreens is people don't apply them properly. So you've got to put enough on. So that's so yes, effectively they are, but if you don't use it properly, then they're not. If that makes sense. Different sunscreens will suit different people, and so you just got to find one that suits you.
What do you use, though, Chris?
Oh, me? Well, I'm too busy. I'm too busy working inside, and well, I was a cricket player, so I still Neutrogena, but I'm not a brand, say any brand names, but we have lots of very good sunscreen. Ego, Hamilton, Neutrogena. There's so many good ones. Two of my patients make sunscreens. I should plug them in, shouldn't I? No, but Cancer Council, excellent. There are lots of good sunscreens. Just look for the SPF factor on there. They can be 30 plus or 50 plus, which basically means if it's 50 plus, you can stay in the sun 50 times longer than if you didn't have sunscreen on. But it's not that I want you to stay in the sun 50 times longer, I just want to decrease that risk of burning. So the most important thing is you put on your sunscreen a bit before you go out, say 10 minutes or so, 20 minutes, just let it soak in a bit, and also practice sun-smart behaviour, avoiding the hot times of the day, appropriate clothing. So it shouldn't be used as something used in isolation.
I don't have melanoma, I have stage 4 breast cancer, but something that your question about sunscreen brought up, I'm always chronically low in vitamin D, and vitamin D can't be absorbed through the sun if you use sunscreen, particularly if you use it effectively. And I just had a question about, have you guys ever noticed a correlation between vitamin D deficiency and melanoma patients? Because there seems to be a correlation between vitamin D deficiency and breast and prostate cancer patients, in that, you know, most people who are diagnosed tend to be chronically low in vitamin D all year round, including in summer.
There are times during the year when you should not be using sun avoidance behaviours or sunscreen and the like, and the ordinary average person will get enough sun exposure and get the amount of vitamin D they need with a reasonable diet and still do all the things we've spoken about in terms of sun avoidance behaviour. Now, vitamin D and melanoma is a very complex issue. One of the things that happens at this time of the year is that sun comes out, people's vitamin D levels go up, and we actually see a spike in melanoma. So is that due to the vitamin D levels going up? There was a vogue some years ago for looking at the idea of giving people vitamin D once they'd had a melanoma, because there was some evidence that it might actually improve outcomes. Problem is that study was never ever going to work, because vitamin D is so easy. You can go down to the local chemist, and I saw it on the weekend. You can buy 500 tablets for $17. The next question is, why aren't we putting it in the water? Because there is some evidence that excess vitamin D is not good for your health. So there is no... the only people who really should be taking vitamin D in our community are pregnant women, breastfeeding women, and women, women...
Yeah, all dermatologists have no bones.
Women who, from various ethnic groups who get very little or no sun exposure. Okay, so they're the major groups that should need it. There is a small number of people who, and a lot of vitamin D testing's been done, who have low vitamin D levels, and it's not unreasonable for them to have a limited supplementation.
But you still get vitamin D coming through. You can still use your sun cream and still get sufficient vitamin D, can't you?
My understanding is no, you can't.
Oh, right.
That if you cover it up completely. So one of my issues is that I occasionally see patients who would tell them about sun exposure, and you see them a year later, and they are so pale it's beyond belief. You think they must have been in the Antarctic for 12 months. And it's almost this obsessional behaviour. You know, they will put sunblock on to go out at 6 o'clock go out bike riding at 6 o'clock on a midwinter's morning, and that's clearly unreasonable. So you do have to do a little bit of counselling to people that when you're not in those peak times, when the sun exposure is less than into medium, that you should not be using sun avoidance behaviour. So the rules, that there are certain rules, but about what you should do. But I think it's something like a teaspoon per arm, teaspoon front and back. So that's a fair amount of sunscreen. People, put a little dab on. That's number one. Number two, you probably should put it on 20 minutes before you're going to get the sun exposure. Number three, depending on how the sunscreen's formulated, and there are some that are designed for hot, sweaty, humid environments, they last a little bit longer. The cheapest sunscreen is still rated at 30 or 50, whatever it says on the bottle, because it has to by law, but it's the sort of stuff that comes off more easily, wipes off. I've never been forgiven in my family because I did the right thing with our 2-year-old and covered him with sunscreen 20 minutes before he went down to the beach and stuck him in a car seat in the back of the car. And, of course, the vinyl car seat, the baby seat just wiped it all off. So he ran around in the sun for half an hour and came home that night with a sunburn, for which my wife and him have never forgiven me, but you learn the lessons. So you've got to be a little bit careful about it, but the answer is, it's not a problem. I'm sorry, I'm on call this week, so I've got to keep an eye on my phone. I will sort that out when we're finished. But that's a situation where you should be replacing your sunscreen. And I bet your industry, there are bottles of the damn stuff sitting everywhere for you to reapply. Yeah. Are you allowed on site without your helmet on, without the flaps on, long sleeves, long trousers, all that sort of stuff?
I work for BHP.
Yeah. The mining industry has been completely far ahead of everybody in the community in terms of occupational health and safety, and it's a good thing too. In fact, Professor MacArthur had to agitate for the hospital to put a sunscreen dispenser on the top of the hospital where people can go out for lunch, and it is a major issue. And it should be almost the way we live these days.
Yeah.
Okay, I think that's, thank you. I think we'll leave it there for the evening. If you'd like to thank our panel. Thank you very much. I think, before we go